we have Dr. Rishikesh Kaza from Hyderabad, India, and Dr. Duncan Chanda from Lusaka. So Dr. Duncan Chanda is our local TB expert physician. He's the director of the HIV/AIDS program at the Adult Infectious Disease Center here in Lusaka. He has been involved in TB and other infectious disease research for over 15 years, and he also serves as the co-director for the International Medical Research and Training in TB Research. He's currently an infectious disease fellow at the University of Zambia School of Medicine here in Lusaka. Welcome, Dr. Chanda.
Thank you very much, Dr. Patel. Good evening, everyone.
Good evening. Okay, so our other moderator today is Dr. Rishikesh Kaza, who is a consultant in medical retina and uveitis services at the CAR campus, Hyderabad, for LP Prasad Eye Institute. He received his medical training from the Maharashtra University of Health Sciences in Nasik, followed by a Diplomate of National Board in Ophthalmology from the LP Prasad Eye Institute, MTC campus in Bhubaneswar. He completed a fellowship in medical retina and uveitis at LV Prasad Eye Institute in Hyderabad. He also completed 2 observerships with Professor Jonathan Trove at Kellogg Eye Center, Ann Arbor, Michigan, and with Dr. Surendra Basti at Northwestern University, Chicago. Dr. Kaza's research interests lie in pathogenesis of retinal vasculitis and ocular tuberculosis. He has also published in peer-reviewed international journals and has been a reviewer for the Indian Journal of Ophthalmology. He has also been the principal investigator for international trials during his tenure at LV Prasad Eye Institute. So welcome, Dr. Kaza.
Thank you, Dr. Patel. Thank you for the introduction. Good evening, everyone. I look forward to this session.
Okay, thank you.
Yeah, so
Dr. Mumbi, I hand over back to you.
thank you very much for the introductions, Dr. Patel. So we will start with the presenter. We only have one presenter today, so she will do the presentation, and then from there we'll keep the questions. At the end, our moderators will make comments, and then at the end we invite everyone who has questions. And please note that you can still post your questions in the chat box. I think I'll allow the moderators in between if there's need to interrupt, or if there's a comment that they need to make during the course of the presentation. Okay, Dr. Nduda, over to you.
Good afternoon. Am I audible?
Yeah.
Yes, we can hear you. If you can go ahead.
All right, thank you. So good afternoon, everyone. Welcome to today's Journal Club presentation from Ndole Teaching Hospital. My names are Dr. Ndunda Mbulo, and my 2 moderators, I want to say thank you very much, are Dr. Kaza and Dr. Chanda Duncan. And today's Journal Club presentation is on clinical epidemiological study on tubercular uveitis. So the term ocular tuberculosis encompasses any infection caused by Mycobacterium tuberculosis. As we know that tuberculosis is a communicable airborne disease which can affect any part of the adnexia, globe, or orbital contents. The most common manifestations are anterior granulomatous and non-granulomatous uveitis. So what is the epidemiology of tubercular uveitis? So in sub-Saharan Africa, it accounts up to 25% of all blindness, which can be attributed to uveitis. And TB uveitis is estimated between 9% and 11% in endemic countries, and between one, I could not find any statistics of the prevalence of TB uveitis in Zambia. If there's anyone who has that, I would really appreciate. So what are the risk factors that are involved in TB uveitis? So the first one is immunocompromised from chronic disease such as diabetes and HIV/AIDS. Healthcare workers are also at risk of developing TB uveitis. Any recent immigrants from endemic areas, and if there's any history of recent exposure, say to someone who's been nursing a TB patient, whether they're suffering from pulmonary or extrapulmonary TB.
Hello, Dr. Ndunda.
Like I said, it can account for either unilateral or bilateral chronic granulomatous maton fat capes. So this is just a picture showing us the granulomatous maton fat capes, as well as the synechia, as you can see here, and iris nodules. So what I wanted to note was the most common type of synechia that you see is the broad band posterior synechia in TB uveitis.
So,
So
just take that page, Dr. Ndunda. Okay. So this slide, if you look at the first image, I'll just expand on what Dr. Ndunda has very well explained. So if you look at the distribution of the keratic precipitates, you'll find that they are in the Alts triangle, forms this sort of a triangle inferiorly. And the KPs get larger as they move towards the periphery. And that's quite common to find in cases of tuberculosis and sarcoidosis, both of them. And as she elaborated on the broad-based posterior synechia, this is typically a broad-based posterior synechia here, which is seen in the middle image. So one important point in the distribution of KPs is that diffuse distribution of KPs, you can have pigmented or non-pigmented mutton fat KPs, which are larger in size. If they do have diffuse distribution, then you're likely to be looking at a viral uveitis rather than tuberculosis. But larger mutton fat KPs in the inferior distribution, typically seen here, pigmented or non-pigmented, both could be seen in tuberculosis as well. You can move on, Dr.
Thank you very much. So what are the clinical clues that you'll find in TB uveitis? So this is a slide showing us in the posterior, this is a slide showing us posterior TB uveitis. So these are fundus photos showing us an active retinal vasculitis with subvascular lesion along the vessels. And this one here at the bottom is showing us an extensive retinal hemorrhage due to vascular occlusions along the supratemporal quadrant. So on the picture here on image D is showing us showing us a fundus fluorescent photo, which shows a mid-late phase of focal vascular toxicity and the absence of any capillary non-perfusion in the retina. And
so this is a study which we did last year, and it got published in Retina this year. So we found 3 important clinical predictors for tuberculosis as the cause or etiology for retinal vasculitis. Now, all of this is pertaining to images of retinal vasculitis, especially in TB endemic countries, which applies to Zambia as well, because Zambia seems to be a TB endemic country too. So this is specifically for the endemic countries, where if you are looking at retinal vasculitis, there are 3 important clues to look at. One is the presence of subvascular focal lesions. That could be retinitis or chorioretinitis lesions, as seen in the inset image in the first left top image. Along with that, overlying that, you can see a slight kinking of the vessel. That is because the underneath the chorioretinitis or retinitis lesion, the focal lesion, there is vascular endothelial growth factor, which is suppress, expressed because of local ischemia. And this ischemia and VEGF release leads to increased cleavage planes within the vessels, and that leads to the vascular kinking, which we have termed as focal vascular tortuosity. What has also been seen that this is away from the areas of capillary non-perfusion, so that is a clue that it is not linked to neovascularization also. So the first clue is subvascular lesions, second clue, focal vascular tortuosity, and third clue, the presence of occlusive vasculitis. Now, those interested, I could share the paper and they can go back and look at what was the positive predictive values of each of them and how they helped reach a diagnosis of tubercular retinal vasculitis in these cases.
Okay.
You can go ahead, Dr. Yeah.
Okay. So again, as Dr. mentioned earlier, the most common is the retinal vasculitis and the presence of chorioretinitis as well, with subvascular active lesions that are present within the retina. And you can also see areas of active and healed subvascular lesions within the retina, as well as chorioretinitis and active retinal vasculitis.
So other than retinal vasculitis, I'm sorry, I'll just interrupt here. Other than retinal vasculitis, there are a few other phenotypic manifestations of ocular tuberculosis, especially in the posterior segment. One is unifocal choroiditis, as we see to the left side of the image, unifocal choroiditis. And if you can imagine the vessel coming out of the choroiditis lesion, you can see plaques within the arteries also. So that is Cayley's arteriolitis there. And the other presentation in the right-hand side image is multifocal choroiditis with a few active lesions in the superior periphery. And the third presentation would be a multifocal serpiginous-like choroiditis, which I think she'll be coming to in the next slide.
Okay. So, so these are fundus.
When I explain it, I think it'll be easier if I do it.
Okay.
Okay. So for the chorioretinitis lesion, in cases, I'm sure you guys would have seen toxoplasma chorioretinitis. If we compare that with tuberculosis, the difference is that the chorioretinitis or retinitis lesion in toxoplasmosis gets reactivated at the periphery, that is the margin of the lesion, because that is where the toxoplasma organism is dormant. So the reactivation occurs at the margin of the lesion commonly. You can have new lesions occurring elsewhere, but the reactivation generally occurs in toxoplasma at the margin of the lesion. But the point to remember in choroiditis or chorioretinitis associated with tubercular uveitis is that the reactivation occurs within the lesion, that is in the center of the lesion and not at the margin. This could be a clinical clue to diagnose TB uveitis. It's important that I'm stressing on clinical clues because our none of the diagnostic tests are gold standard for tuberculosis. So we have to rely on clinical clues more than anything, especially in tuberculosis, since in endemic countries, every other person or every third person may have a positive tuberculin skin test. And that may be the only source of labeling them as TB. But if we look at the clinical clues and put them into the pattern or go into pattern recognition, it might help you reach a diagnosis sooner than later. You can
So I also,
yeah.
So I also wanted to add on that if we see any active chororetinitis within the chororetinal atrophy, this can be an important early diagnosis for intraocular TB. So what are the ocular investigations that we can do? First one, we can do a fundus fluorescein angiography, which can help us to look for chronic tuberculosis uveitis with disc edema or any macular edema, where you see presence of hyperfluorescence. We can also do a spectral domain optical coherent tomography, This can be used to confirm macular edema, which is one of the most common complications of posterior ocular TB uveitis. And then we also, the laboratory investigations that can be done are tuberculin skin test, which can help us to detect latent or active TB. So we use a protein purified derivative of intradermal injections of 5 tuberculin units and a positive tuberculin skin test and in duration greater than 10 millimeters or more after 48 to 72 hours is said to be positive. But we also must bear in mind that there are what are known as false positive, especially in our setup where most of our patients have been given a BCG vaccine, which can result to a false positive, or in cases of patients who are diabetic, as well as some health workers can also have a positive tuberculin skin test. We should also be mindful of false negative tuberculin skin tests, which can occur in immunocompromised, immunosuppressed patients, to say, in elderly patients as well as malnourished patients. So in order for us to confirm if it's a positive tuberculin skin test, we can do additional tests such as the interferon gamma release assay, quantiferon TB gold, which helps us to detect Mycobacterium tuberculosis by measuring the interferon gamma release in response to the antigens representing the M tuberculosis. And this one is less sensitive to detect latent TB. So we can also use the polymerase chain reaction, which helps us to amplify the DNA of small genomic sequences from a very minute quantities of ocular tissue samples. Other tubercular uveitis investigations that we can do that are commonly used are chest radiology and computed tomography scans, especially in active pulmonary TB cases. We can do a sputum smear and culture and ultrasonography, which will help us differentiate between the TB tuberculomas, which can mimic intraocular malignancies. So, the diagnosis and management, yes?
Yeah, let me just come on TB diagnostics. I think one of the issues I like pointing out when it comes to diagnostics in general is we don't do diagnostics just in the void. We should have a very good clinical reason why we're going to do this. So one of the reasons I'm coming on this is the issue of PPD and how over the years in the high burden countries like Zambia, it has been so much discouraged and we have had very conflicting results. We do use it in cases where we have a very high clinical suspicion for tuberculosis, but we have nothing to hold on to that. And I think going through the literature around the ocular tuberculosis, this is one of the things we have to think about. PPD and interferon gamma put together with your clinical findings. I'd be interested to see what Dr. Kaza's paper, rather research, which referred to whether they actually added any laboratory investigations. PCR, in terms of ocular TB, I was trying to get a handle of that, but looks like you have very few volumes of samples to work with, and so also likely to get a false positive. So in context, I think we have to put everything in context. What you are saying clinically, what you are suspecting clinically, and then what you get from your laboratory. We shouldn't be discouraged. I mean, I've seen a number of papers on IGRA and also how they can be difficult to interpret in high burden tuberculosis. I'd like to hear from Dr. Kaza whether they actually use IGRA and the PPD generally in TB diagnostics in India or to do with ocular TB.
I think, Dr. Chanda, you brought out great points. I mean, I was going to ask you your opinion on these any which way later. So since we brought out the discussion, we don't use IGRA too often. And I believe that tuberculin skin test, PPD, and IGRA are basically are suggestive of the same thing, a latent infection or a previous infection, and does not indicate of any activity or active disease. So, and tuberculin skin test is way cheaper. So we do get tuberculin skin test done for all our ocular TB patients or all our uveitis patients actually in general in our scenario. But we don't rely on that for starting them on anti-tubercular therapy. And like I said, we first, that's why the clinical clues to diagnosis is very important. Based on that, if the tuberculin skin test is also positive, very few times a chest X-ray comes out to be showing of any previous insult. However, CT scan becomes quite expensive for the patients to get it done. And since India is also a poor country, it's difficult for us to get an HRCT or a contrast enhanced CT in our patients on a routine basis. So that is when we rely on a tuberculin skin test, not solely, but on the basis of clinical suspicion and tuberculin skin test to get us to define a treatment approach. Now, having said that, I would still say that IGRA, we would do it very less, very rarely in patients.
All right. I agree. Probably that's what largely also would obtain here. We do try to use a skin test when it's available for some few cases of where it's expecting ultra-pulmonary TB. And then we have no handle on anything. And sometimes I've seen very dramatic reactions of TB if the patient has active tuberculosis. Yes, if you are suspecting a patient to have active tuberculosis. So I think it's something we could try going forward in terms of suspected ocular TB and see what we can get around that. We can discuss at the end of the day whether we could think about the research topic in that area.
Yeah, definitely.
Okay.
Because Zambia does not have any literature on ocular tuberculosis. I think there's a great scope there. When I talk later, I'll talk about the statistics in Africa. I've drawn out a few statistics in Africa on ocular tuberculosis and tuberculosis in general. So we can have it at the end. I would also say that you brought out a very good point on PCR and the quantities being small and the false positive or false negative also. So I would completely agree with you on that. And if you go to see the diagnosis of ocular tuberculosis, how they've classified it as possible, probable, and confirmed, PCR actually ranks very low. It does not rank with microbiological tissue sampling diagnosis. So PCR is as good as having a positive tuberculin skin test actually. So that's your point there, that PCR may not be very helpful, especially in endemic countries.
Okay. Thank you for that contribution. So now I'll talk about diagnostic criteria of intraocular TB. So the diagnosis and to say the management of TB uveitis poses a significant challenge due to lack of specific diagnostic criteria and different views of diagnostic criteria. So according to Gupta, where it states one clinical feature of intraocular TB, the ones I had mentioned, the clinical clues, and one of the following documented exposure of immunological evidence, where if there's a history of a patient who had recently contact with a TB patient or a family member with extrapulmonary or pulmonary TB, with one of the following of radiological evidence and extraocular TB signs, with microbiological evidence of ocular samples to say. This is where we define it as confirmed ocular TB uveitis. And then if there is one clinical feature of intraocular TB with one of the following documented exposure and immunological evidence, with one of the following radiological evidence and extraocular signs, with extraocular microbiological evidence, this is defined as probable. And then if there's just one clinical feature of intraocular TB with one of the following documented exposure with immunological evidence and one of the following radiological evidence with extraocular TB signs, this is known as possible, without any evidence of microbiological evidence. So if there's just one clinical feature of intraocular TB, this is also known as possible. So now talk about the treatment. So the treatment of TB uveitis, we just use a standard anti-TB treatment for 6 months of therapy based on WHO recommendations. The first 8 weeks, we can use rifampicin, azonizide, ethambutol, and pyrazinamide. And in the next 18 weeks, we can just use rifampicin and azonizide. So there is a controversial talk to say about the use of corticosteroids, and I'm hoping Dr. Kaza can share some light on the treatment of TB uveitis.
Do you want to have this discussion now or at the end of the presentation?
I think we should have it at the end of the presentation. And then I'm just encouraging the participants that if you have any questions, please keep them coming on. You can type them on the chat group. We are going to ask at the end. And then if you have any burning questions, you're going to ask them verbally later.
Sure.
Okay. All right, so that marks the end of the presentation on TB uveitis. So now we'll talk about our journal of today. This journal is from the Journal of Ophthalmology, and it's on clinical and epidemiological study on tubercular uveitis in a tertiary eye center in Italy. It was published on the 23rd of March. It ranked 22, and unfortunately, I could not find the impact factor. So there's a few data that is available on clinical presentation and manifestation and outcomes of TB uveitis in non-endemic countries such as Italy. And in the Italian population, the clinical course and clinical outcomes of TB uveitis were reported, with the effectiveness of ATT in reducing uveitis relapses and visual outcomes as well. And there's currently no data available on the effect of early ATT on long-term clinical outcomes in patients with TB uveitis. So with that being said, this leads us to the aim of this study, which is to describe the clinical and epidemiological characteristics of patients with TB uveitis referred to at a tertiary eye center in Rome, Italy. So the study setting, it was done in Sapienza, University of Rome, Italy, in 2008 to 2018. So it was a period of 10 years. So the methodology, this was a retrospective study. They had 3,743 chat patients, and out of the 3,743, they found that 28 patients had endogenous uveitis. So they had grouped these patients into two main groups, and these were based on clinical histories of the patients within a year. So group A were patients with uveitis without a previous diagnosis of tuberculosis, and group B were patients with the first episode of TB uveitis on first presentation within the year. So they had an inclusion criteria. The first one was the diagnosis of uveitis with or without involvement of the optic nerve, a positive tuberculin skin test, which was greater than 10 millimeters within 72 hours. And in doubtful cases, they used positive interferon gamma release assay and quantiferon TB gold. And they also used specific treatment with ATT during the follow-ups. They had an exclusion criteria where the patients with other syndromes or infections were excluded, acquired immunodeficiency patients were excluded, and patients in which diagnosis of TB TB was excluded based on results of clinical evaluation, tuberculin skin test. So they conducted a very comprehensive evaluation of each participant. They also had ocular evaluation using the Snellen's chart. They also did slit lamp examinations. They measured the interocular pressure with the Goldman applanation tonometry, and they also did fundus examinations. They did fluoroangiography when they found patients who had posterior and diffused uveitis. They also studied the macula, or they did macular morphology using the spectral domain optical coherence tomography. And all these diagnoses were made by a uveitis specialist. The data analysis. So the statistical test, they used an exact Fisher test and an independent t-test. This this was used to compare the data between the two groups. So they compared the visual acuity, the number of ocular recurrences, and the ocular complications, and the paired sample t-test evaluated changes in best corrected visual acuity within the two groups, and the p-values were also considered statistically significant. So after they had gathered all that, they grouped their results into, like I said, they had two groups of patients, and according to the results, we noted that more females they've had more females who were affected with TB uveitis, and they also classified their findings, or I can say they also classified their uveitis according to the international uveitis study group, where they put it into anterior, intermediate, posterior, and patients had anterior bilateral uveitis. And they also recorded any tubercular uveitis complications, where they've noted that the most common one was cystoid macular edema in most of the cases. And they also treated this cystoid macular edema with acetazolamide and corticosteroids. And for those who had characterized, they also performed characterized surgeries on them. And those who had glaucoma, they gave them anti-glaucoma drugs, and only one, they performed an iridectomy. So I just want to draw your attention to this particular slide. So ATT was given to both groups of patients, the group A's and the group B's. And like I mentioned earlier, that the group A's were the patients who had uveitis on first visit. And then the group B's, they made a diagnosis of TB uveitis. So they gave ATT to both groups, and they showed that group B showed a significant improvement of mean best corrected visual acuity compared to group A, which showed no significant improvement in the mean best corrected visual acuity. So I also want to mention that during the trial of giving ATT, they also had documented any side effects, both topical or systemic side effects as well. So among that, they also had a patient who they took interest. They had found the ophthalmic and fluoresceint angiography of a patient with a posterior uveitis. Image A showing multiple cream yellow active lesions with increase of choroidal fluorescein at fundus fluoroangiography. And after 12 months of treatment with ATT, they noticed a fading in active lesion and molting pigment with decreased choroidal fluorescence. So now I'll talk about the author's interpretation. So there's a decrease in incidence of tubercular uveitis compared to the previous studies due to improved diagnostic technology, which helped them to diagnose the difference between histoplasmosis, sarcoidosis, and other autoimmune conditions that they thought previously was TB uveitis. So there was a decrease from 1.76 in 1986 and 1999, and 1.76 in 1999 and 2003 to the current study of 0.75 from 2008 to 2018. So you can see that there is a decrease. And then the diagnosis of tubercular uveitis was based on the presence of clinical signs of uveitis associated with positive tuberculin skin tests of greater than 10 millimeters at 72 hours, and the interferon gamma release assay test, and exclusion of other causes of uveitis. The epidemiological evidence of an earlier onset of TB in patients who came from endemic areas. They also observed no difference in the type of uveal involvement by TB in granulomatous and non-granulomatous monolateral bilateral uveitis. And the comparison of both groups showed that anterior uveitis was the most common uveitis in group A. So the study findings also showed that tubercular etiology should be investigated in patients with anterior uveitis, and that ATT has no influence on the extension of vasculitis or visual acuity in patients with retinal vasculitis. So what is the conclusion? So an earlier diagnosis and a specific treatment of tubercular uveitis decreases the recurrences and improves visual acuity significantly, and that TB should be considered as a possible cause of idiopathic uveitis. So now we'll critique our article using Marie. So the methods, the study design, the study period, and the location was clearly stated, and the sample size was given. There were 28 out of 3,743 patients. They did mention the inclusion and exclusion criteria, and also the ethical approval was obtained. So it was a retrospective, the assignment was that it was a retrospective and a comparative study. 28 out of 3,743 charts of patients were reviewed, and appropriate methods were used, and like I mentioned, the participants were divided into two groups. The assessment. So the study question and the aim was answered. I thought there was a good follow-up of participants, and the diagnosis was made by uveitis specialist. So this is where we would think about one uveitis specialist making the diagnosis. We can rely on it. At the same time, maybe we can question elements of biasness, being one uveitis specialist and reviewing all those 3,743 files. So that's a question or a thought. The results, the data was well presented, and the large sample size, initially started with a large sample size, and then it was minimized to a small sample size, and all subjects were of different ethnicity. So the interpretation, the tubercular etiology should be investigated in patients with anterior uveitis. And treatment with treatment with ATT significantly improves visual outcomes. It also reduces frequency of relapses and ocular complications. As for the extrapolation, the duration was rather lengthy, and a small sample size was obtained eventually. But from 2008 to 2018, it was quite lengthy, but it makes sense because the prevalence of tuberculosis uveitis to stay is not so much in Italy as compared to, for example, Zambia. So the duration was rather lengthy. But in our clinical practice, there's need for a comprehensive ocular and systemic history, and all patients with anterior uveitis should be, all patients with anterior uveitis, TB uveitis should be excluded. So I just want to say we can adopt this if we go with a small sample size, because looking at the fact that TB is rather endemic, looking at the fact that we're an endemic country, there's no need for a lengthy study period, or if we do adopt this study, if we go for a lengthy period, the challenge is that we have poor file keeping. So again, it's a two-way thing. We can adopt it, but I think for the period of 10 years would be too much for us, because we have got poor record keeping. And most of our patients, we make a diagnosis of anterior uveitis, but there is need to exclude TB as one of the causes, seeing as that it can also present as a non-granulomatous form.
Okay, Doc, let me just come in at that stage. Oh, we actually done? Okay, yeah. I just want to emphasize on the evaluation and the study design. I think you have pointed out something right at the end about our file and record keeping. So this was a retrospective study, and they reviewed more than 3,000 files. Okay, over a 10-year period. Clearly, when they refer to files here, they're not very clear whether they are digital documents or they were paper files. So in our setting, you like to point out that's almost an impossible task, the way we keep our thing. There's a study I'm carrying out right now over COVID. This is over a two-month period. I can assure you it's chaotic to put the data together in a retrospective way. So then you also, just to be clear about the assessment, when they mention that uveitis specialists actually assessed that, I wasn't very sure about what they meant, because this was a retrospective study. My only assumption there was that they actually only use uveitis specialists to make a diagnosis of TB. So it's not like one specialist, it's various specialists over the 10-year period. That's where I understand it, because they pretty much, and they didn't do the allocation themselves. Again, it's retrospectively, which in the methods didn't come out very clearly. So the first group A, these patients had uveitis for some time before a diagnosis of TB uveitis was made. In group B, looks like on the first contact with the uveitis specialist or with ophthalmology unit, the first suspicion was TB uveitis. So one group looks like they had a high suspicion for TB, that's group B, whereas for group A, they came to conclusion of TB probably after they tried other things. Because of that, yeah. I don't know what Dr. Kaza thinks about that design and what they're trying to say. If I'm right about my observation on that.
Absolutely, Dr. Chanda. I would definitely agree with you. So if group A, if they're drawing the conclusion, first of all, the numbers are quite low, which is expected because they are not a TB endemic country. And to make a strong conclusion from that, I would disagree. Second, like you pointed out, the group A versus group B, where 1 year versus minimum 1 year from diagnosis or from present, like when the presenting symptoms started, to 1 year when they started ATT to immediate starting ATT. I think that design is also probably not the best way to go ahead, because if they were thinking of the other diagnosis, then they should mention what other diagnosis they thought of, what did they treat for, whether they resolved or not. I would also pick out one more thing. They said that they found anterior uveitis to be the most common. Whereas if you actually look in your settings, especially in tertiary care centers, you'll find that the data is skewed towards the posterior uveitis. And that may be because the patients with anterior uveitis may not come at the first go to the hospital, because they are self-resolving to some extent. Second, the visual acuity, reduction in visual acuity may not be that prominent. And third, they may receive drops elsewhere or from practitioners elsewhere, and they may not end up coming to you in the first go itself. So that could also be one of the points where they would have been skewed. I would say if you look at endemics, then we would be skewed towards posterior uveitis than anterior uveitis, although anterior uveitis is the most common presentation. So my takeaway from this article is I would stress on the fact that we cannot apply it to our settings like Zambia or India, because our scenarios are quite different to what they see in Italy. Interestingly, if you noted, majority of the patients in their cohort are also from the endemic countries. You looked at the countries, they've listed countries of origins, and they've also mentioned somewhere in the article that majority of the patients were from the endemic countries. I would also like to ask Dr. Chanda whether doing both TST and IGRA was actually necessary, like they did there. For a lot of patients, I think 11 patients had IGRA also done, apart
I
from
think,
TST.
yeah, good observation. I think this is typical of countries which have a lot of resources. So they tend to do a lot of tests. Actually, if you have practiced like in an American environment, I guess it's the same thing in Italy. People run a batch of tests based on just one thing they think about. And whatever comes out positive, they tend to go in that direction. So I think this is what was happening here. And because it is a retrospective study, you have no control over it. So you use both IGRA and you use TST, which again, if you look at it, individually, they should be representing most the same thing. But when you add them together, then you might actually increase the incidence of the disease. Okay, instead of saying either, but you are saying, instead of saying both will be counted one, but either is counted as one. So if IGRA was negative, but TST was positive, then you say the patient had positive TB. Yeah. So this is the problem of trying to do diagnosis of one disease using a lot of tests. One of them definitely will come out positive. Yeah. And the chances of a false positive is quite very high.
I would also ask Dr. Chanda, what is your take on the TB burden in Zambia? I was looking through the statistics. One of the reports published in 2013 stated that they had 410 per 100,000, which had reduced over time to 258 per 100,000. So what is your take on tuberculosis?
I think our numbers should be going up. I'm afraid we have been reporting around 40,000, 38,000 per year. But our projections, according to WHO, should be about 52,000 per year. There was a study which was done in a limited number of centers a couple of years ago by Zambia HIV-related TB group. And they had incidences running from 400 per 100,000, and in Kanyama, one of the places in around here, the city, there were about 758,000 per 100,000. So our figures are not really up to scratch, and there are some things we are doing. I sit on the National TB Technical Working Group. We are trying to actually try and correct that. Our reporting hasn't been very good, so the figures could be very, very high. Yeah, and even I'll give you an example, a practical example. 4 years ago, we used to report 32 cases of drug-resistant TB to 50 cases. Currently, we think we're about 500, and we think we're more than 1,000 cases by the end of this year. So we have improved in the diagnostics, both for drug resistance and drug-sensitive TB. So the numbers we have been reporting previously have been lower than what you would expect. Yeah.
Yeah, so there is a question from one of the participants, Dr. Sylvia. She's asking, how often do we see extraocular findings in TB uveitis, and which extraocular findings are more commonly seen? I think it's directed to Dr. Kaza. I think maybe perhaps you can also combine and mention what percentage of the TB is ocular. Yeah, because
Correct.
we rarely, we see a lot of patients with uveitis, but so far I think only one diagnosis, I think from the time that I've seen this patient, I've made that diagnosis.
So under the blanket of ocular TB and extraocular TB, we find that the most common phenotype of ocular TB is uveitis. However, the extraocular TB can range from conjunctival involvement like conjunctivitis, flick-tenular conjunctivitis. I'm sure all of you would have come across the term somewhere. Scleritis, you can have nodular or diffuse scleritis, especially common where you get a nodular scleritis with a pinpoint infective focus. That's quite common in our endemic settings. The other thing could be involvement of lacrimal glands, or as a part of extraocular tuberculosis, you can also have eyelid involvement. And all of these may be seen. And in addition, the final stage, I've seen one patient where a tubercular panophthalmitis was diagnosed. It started out with intraocular tuberculosis, a panuveitis, which went on to involve the cornea. And finally, she had eyelid involvement and limitation of extraocular muscles. So this is a case report which is going to come out soon in the next week or so. It's been accepted to Indian Journal of Ophthalmology, and we've published this. But we saw the patient last year. Unfortunately, the patient lost her eye and we had to eviscerate it. So very interesting case report. Once it comes out, I think whoever's interested can go and look into the spread of intraocular to extraocular TB. Having said that, I would say that the most common manifestations or presentation would still be uveitis in our clinical practice at least.
Are you able to give the proportion of ocular TB in patients who have TB in general?
Yeah, so ocular TB would be less than 10% in tuberculosis or TB in general, actually. If you go through literature, hardly any patient with ocular TB, it applies vice versa too. The patients with ocular TB have less than 25% chance of pulmonary or extrapulmonary other site involvement. And for pulmonary TB, less than 10% actually have ocular TB. I've also got some interesting statistics since we've brought this up from Africa itself. There's a study from Malawi where in tuberculosis patients, 3% had choroidal granulomas, that is in pulmonary TB patients. And also 60% patients of extrapulmonary TB may not have diagnosed pulmonary TB, according to that study. The other statistic from Africa, which is pertaining to the question you put forward, ocular TB in TB patients in sub-Saharan Africa range from 1.72 to 4%. Whereas if you go through literature in India, it ranges to less than 10%. So 1.72 to 4%, but roughly we can remember the figures 4 to 10%. So it's a small population that you find ocular TB when you compare TB patients in general. However, ocular TB, the important takeaway here is that ocular TB may not be associated with pulmonary or other extrapulmonary TB involvement.
Sorry, Dr. Mumbi, I have a statement to make.
Yes, yes, Doc.
Yes. I also wanted to find out from Dr. Kaza. He said that he would shed more light on the use of corticosteroids in TB uveitis, because according to the study, they found patients with posterior uveitis, and they were administered, those who had posterior uveitis and diffuse uveitis were given oral corticosteroids or ocular injections of corticosteroids. So I wanted to find out what's his take on the use of corticosteroids, because some of the literature says patients would resolve just on the use of ATT without the need of corticosteroids.
Thank you for bringing this up, Dolo. Do we have time? Can I take this question, Dr. Mumbi, or are we?
Yes, I think we still have some 5 minutes. We'll have some 5 minutes. Dr. Chanda, is that okay with you? Just
that's fine.
Okay, thank you.
All right, I'll try and quickly answer this question. So in our practice, I would state that one thing is different. The burden of HIV may not be as high as you might see in Zambia. So it's important to understand that use of corticosteroids in HIV co-infection with TB may not be uh, that necessary, and also it may be risky. So having said that, I'll shed some light on what we do in our practice. So a word of caution that in HIV patients, take expert opinion and then start using steroids. Do not start them without knowing the other factors. So in our in our scenario, especially in TB endemic countries, I would state that there are two phenotypes which respond very well to anti-tubercular therapy alone without the use of corticosteroids. That is in fact linked to the pathogenesis itself. That may be the talk for another day. But there would be unifocal choroiditis, subretinal abscess, or retinal vasculitis. All three of these respond very well to anti-tubercular therapy alone, because most of the tuberculosis or ocular TB are possibacillary. However, subretinal abscesses have known to be found to have TB microorganisms in them, and a lot of studies have shown that. So these three entities respond better to ATT alone. On the other hand, multifocal choroiditis or serpiginous-like choroiditis respond very well to steroids, and the use of ATT in them is to reduce the risk of recurrences, and there is literature to support this evidence. Secondly, we would start most of the patients presenting with posterior uveitis, especially the ones which I mentioned, serpiginous-like choroiditis or multifocal choroiditis, with ATT and steroids together or concurrently, and not wait or delay the start of corticosteroids. So typically, we would keep the steroids for at least 2 to 3 months before the ATT is completed. That means I would stop the steroids within, say, 4 months or 6 months if the ATT is running for 9 months or so. And then, so there is a period where you're giving ATT alone. So the important finding there, the takeaway there would be that not to give steroids alone. They do respond to steroids, but do not be confused that you must give ATT for the resolution or to prevent recurrences, because when it recurs, then it may be worse than what was before.
Yes, so I think just to comment on that one, Dr. Kaza, we had a 25-year-old lady that we started seeing early this year. So previously had anterior uveitis from 2018, and the patient had been periocular, the steroids. And later on, when we saw the patient, we noticed that patient had posterior uveitis. We gave intravitreal triamcinolone, and then the patient responded, and again developed uveitis again, posterior uveitis. We started on oral steroids. So we gave for some time until we started seeing those tubercular exudates, the yellowish at the retina, and also patient also had exudative retinal detachment. So based on that, we started ATT. Patient responded, but the challenge we had was that the patient had gained weight so much. So she was not willing again to go for another course of steroids. That was after we tapered off. So we decided to give triamcinolone locally. From that time, the patient had responded, but this has been 4 weeks. So I don't know, like, when, at what point do you start, do you stop steroids? I mean, the oral steroids? And then are there chances, is there a possibility that instead of giving oral steroids, you can give other alternative drugs?
I'll answer that. Thank you for the question, Dr. Mumbi. So anterior uveitis, you can treat only with topical steroids alone. You don't need to supplement it with any oral or periocular steroids. So very rarely would you need any oral steroids for anterior uveitis alone. But in this case, we talk about posterior uveitis, then I would stay away for some time from periocular steroids or intraocular steroids, because especially when you have choroiditis or retinitis lesions, because you may not entirely know what the diagnosis is. And in those cases, oral steroids may be better off or safer to be used than periocular intravitreal. But then again, if you must give, then you could, if you want to do some form of local therapy in those cases where you cannot do oral steroids or when you know the follow-up is not going to be good, then you would rather do intravitreal rather than periocular, because intravitreal can at least be removed. You can go inside and remove it. You do a core vitrectomy and remove the drug altogether. That is a possibility. But whereas with periocular, like a posterior subtenance injection or a transeptal injection, you have no chance of getting the steroids out. But having said that, I would still say that oral steroids are the safer option and you can start them. It's important to know the tapering schedule. You can do a 2-weekly taper, which is useful and safe also to follow, but to rule out HIV in those patients. So a 2-weekly taper after you started ATT. So typically, let's say a man weighing 80 kilos, you can start at 60. You need not do 1 milligram per kg body weight. 60 is as far as I go for ocular, because you may not need more than that for the eye. So 60 milligrams you can start at and do a 2-weekly taper, bring it down to 50, 40, 30, and 20. From then on, your tapering schedule can get slower. So probably spend a little more time or 2 to 3 weekly, depending on how the patient is responding to it. So typically, as I said, 4 to 6 months of oral steroids, that means 60, 40, 60, 50, 40, 30, and 20, which adds up to about 6 weeks or more than that, actually, 2 months or so, little more than 2 months. And beyond that, you can put them on 15 and 10 for 3 weeks each or 2 weeks each will also do. And the lower doses for a little longer. So you would bring it up to 4 to 6 months of oral steroids along with ATT. And typically you would continue using ATT beyond the oral steroids. That's what I would stress on for everyone whoever's seeing tuberculosis uveitis in their practice, that ATT should be continued beyond the stopping of oral steroids in practice.
Yeah, so just as we wind up, there are 2 questions that have been asked by Dr. Nandasaba. The first one concerns the studies. So she's asking what could have influenced the exclusion of patients with the acquired immunodeficiency syndrome. And then the second one is in our various experiences. I think she's referring this particular one to both India and also us here. In our various experiences, how often do we see patients with sarcoidosis? She says, personally, I haven't yet. What is the situation in Zambia and in India for sarcoidosis? I think maybe both ocular and just systemic for Dr. Chanda and Dr. Kaza. Yeah, do you often see sarcoidosis in your practice?
Dr. Chanda?
All right. So largely when we are suspecting sarcoidosis, we defer this to the ophthalmologist. But from the last discussion with him, we are very, very rare of sarcoid. We have a few. The prevalence is very, very low. Yeah.
So I would say the prevalence of sarcoidosis would be underreported in most cases. It's not it was thought not to be very common in India also. However, actually the disease cannot be differentiated very well from tuberculosis. If you look at a few articles on tuberculosis and sarcoidosis, what they've termed as TV sarcoid spectrum, they consider tuberculosis to lie on one side and sarcoidosis to lie on the other. And the two in between diseases as tuberculosarcoid and sarcoid of tuberculosis, depending on the clinical features and depending on the investigations, the outcome of the investigation. So the presentation may be very similar, and that is why we would, being an endemic country for tuberculosis, we would more likely be, more likely err towards the diagnosis of an infectious entity where the treatment is certain, rather than diagnosing sarcoidosis where the treatment is steroids or immunosuppression, which can actually have a very bad effect if it is tuberculosis. So typically the patients who are diagnosis may have treated with anti-tubercular therapy, and then they are still not resolved, and then you think of sarcoidosis as the possible diagnosis. So I would say that we do see a lot of cases of sarcoidosis in India, however, less than tuberculosis. And also it's a difficult diagnosis to make, but I would urge everyone to go back and look at the international guidelines for diagnosis of sarcoidosis, where the stress on a negative tuberculin test is quite high, where the positive predictive value of a negative tuberculin test with the presence of lymph nodes, hilar lymphadenopathy on a CT scan, giving a very high positive predictive value for sarcoidosis.
And Dr. Mbulo, the first question, what would have influenced the exclusion of patients with AIDS?
So I think probably because they were trying to just focus purely on ocular TB features, because HIV also has its own ocular manifestations, which can also be seen together with TB features, making it difficult to diagnose purely TB features to say. So they can mimic, like we can have TMV retinitis. I would think that's all.
Okay.
If there's anyone to add.
Okay, Dr. Nandasaba, is your question answered satisfactorily?
Yes, that has been okay. That has been satisfactory. Thank you, Doc.
Okay, thank you. So I think we have run out of time. We have overshot, I think, by 12 minutes or so. So if there are any closing remarks, maybe from the moderators and the presenters.
I would like to say thank you very much for your attention. I would like to thank my two moderators, and I would like to thank everyone for listening. It has been a learning opportunity for me, and I just want to say God bless.
All right. Thank you very much for this presentation and the discussions. And thank you for having me as an outsider, being from ID. I think we should be having a lot of these discussions between infectious diseases and the ophthalmology going forward. There are a lot of cases, I think, which we can be discussing and being learning points. And also to work in a multidisciplinary approach when we are dealing with difficult cases, like we did on that other case with Willard. I think that's the way to go. I'm also glad to have met Dr. Kaza. I hope we can keep in touch and let us probably look at what we can do going forward in terms of ocular TB and the other areas of infectious diseases where we can do some collaboration. Thank you very much.
Yeah, Dr. Sanda, before you go and before Dr. Kaza come in, I think it's an opportunity that Dr. Kaza has mentioned. I think there's so many studies that have been done concerning TB when you try to check on Zambia, but none, as he mentioned, on TB. So what are some of the areas, maybe Dr. Kaza will come in also at the end, that you think we need to do on the ocular TB among our patients? I'm very sure that we don't have less TB. We must have a lot, probably maybe even more than India, looking at our prevalence.
Yeah, I think when I was reading for this presentation, I came across an interesting paper from within Africa, where they were assessing for presence of ocular TB in MDR patients. But also what came to mind is more severe ill patients from the studies I've done previously doing with TB, they tend to have mycobacteremia. And that brings the question is how often is that seedling of hematogenous going to the eyes? And are we missing ocular TB? Most likely. So those are some of the areas I would like us to investigate. And this might be so more if we're going to have patients with the TB meningitis, and maybe we miss the ocular TB presentation. So I think there are a lot of things we can think around. Excuse my thinking around the the eye is very muddled, but I think I'm learning a lot of things. Yeah.
Thank you, Dr. Chanda. And Dr. Kaza?
Yeah, so I'd like to start with the presenter. I think she made an excellent presentation, Dr. Mbulo. Congratulations for that, and I'm glad that I could be part of this meeting, and I've learned a lot from Dr. Chanda, and I'm sure we'll keep interacting in some way or the other. I have a suggestion. Maybe you could look at the epidemiological data to start with of TB, and also get your, probably have better documentation, so you can from now on that you can actually collate data probably a year or two into practice. I would say that 10 years is definitely not necessary for Zambia, because the prevalence of TB being high, I would say that within a year you might get a lot of patients and you might collect a lot of data. So one is look at your records and maybe target an epidemiological study from Zambia where the prevalence of the TB may be looked at. Second, ocular TB versus pulmonary or extrapulmonary or tuberculosis patients as such can be seen, and you could probably compute the data of the phenotypic aspects of TB, where you can have posterior, anterior, or intermediate or panuveitis, and you can come up with data like that. These would be two low-hanging fruits where you could actually get on with it very quickly, because there is really a lack of literature from Zambia, and I'm sure that they would get published very quickly. So I think these are the two things you can target in the first book.
I would like to thank everyone, the participants and the presenters and the moderator. It's a lot of work that you put in, and it's a lot of sacrifice, especially for Dr. Chanda, who also needs to go back, looking at the pressure that is ongoing. And also for Dr. Kaza, who is extremely busy. I know the long working hours, finishing at 22 hours and be able to be there for the presenter. And Dr. Mbulo, who has been excellent. And also to thank the mentor, Dr. Funjika Inindola, who has always provided, and the team. It's interesting that the team in Indola, the presentation is not only for one person, but it's for the entire team. I like the spirit of Indola. Please keep it up and continue the same. We'd like also to inform everyone that next week we'll be doing our focus is not really in ophthalmology, but it's on meta-analysis. Our moderator is Dr. Gishui, has done quite extensive studies. So I'd like to encourage everyone to come and understand and listen what meta-analysis and systemic reviews really mean. Thank you everyone for coming and participating.
Thank you.
Thank you.
Thank you.
Thank you.
Do I look cool? Do I look cool?
That's a nice one.
That's a nice one.
Yeah.
Yes, it does.
Yes.
It does look cool.
All right, bye.
Thank you, bye.
Thank you. Bye-bye.